So my name is Fabienne Mackay, and usually I don't talk about dendritic cells. I usually talk about B cells. I talk a lot about lupus, I have to say. But today I thought, because of the theme of this symposium, I'd show you some very recent data in the lab demonstrating that in chronic lymphocytic leukemia, which is a form of leukemia, we have loss of plasmacytoid dendritic cells. And the work you're going to see has been done by a very talented PhD student in my lab, Damien Saulep-Easton. So what is CLL? I'll just give you a quick background. So the reason why I started to work on this is because here at the Alfred, we have a very big clinic, hematological clinic, dealing with all kinds of different leukemias, but also homeostasis, and also lots of patients going to the Alfred Hospital with these conditions, and a very strong research group on hematology. So CLL is characterized by the expansions of leukemic B cells, which express CD19 and CD5. It's a quite of a common form of leukemia. It generally can happen more later in life. The median age is around about 50 years old. And there are two forms of the disease, two clinical courses. One is called indolent. So often patients actually are picked up randomly in the clinic, and then they are just picked up in hematology or just in blood work with some lymphocytosis, and 6 months down the road they'll be diagnosed with either indolent or progressive. So indolent doesn't require any treatment. It is stable. We don't give them any treatment, but there's no advantage in giving them any treatment. And then the progressive patients will see their counts going up over time, and they need to be treated with chemo. And over time, a number of markers have been discovered which more or less reliably correlate with what I call more favorable, less favorable, or actually indolent or progressive disease. So there is also a model of CLL that we have in mice. It's called the TCL1 transgenic mice. So TCL1 stands for T-cell leukemia gene, and it's been constructed in a way that it's in front of a B-cell specific promoter. And then the mice develop a form of aggressive CLL with also the expansion of CD19 positive, CD5 positive B cells. So there's one thing that interests me. So the reason why we got into this is because through discussion with hematologists here at the Alfred, I was always a bit curious about leukemia. And the thing that I thought was really surprising is that clinicians actually, even with current chemotherapy protocols, are very good at controlling tumor burden. So we can control tumor burden. But at the same token, we're not saving the patients, we're not curing this disease. And a good 3/4 of them actually will end up in intensive care at the Alfred, and many of them will die not of the cancer really, but from a complication, very severe complication with an infection. So the one thing that characterizes CLL very early on, even in the indolent phase of the disease, and when they have so-called, a stable CLL, is a defective immune system. So they are immunocompromised quite early in the disease. And that's characterized by many things, including a poor vaccination response, poor complement activation, impaired numbers of T cells, generally a dysfunctional immune system. They're more susceptible to infections. That's often why they're picked up randomly in blood work, actually. They're coming to a respiratory unit or somewhere else, and then suddenly they realize that they've got something wrong with CLL. So the issue there is it happens early, and no one's really worried much about the immunosuppression in these patients, so how it can affect the outcome with treatment. So as I said, the focus in tumor and cancer in general is not just true for leukemia, it's tumor debulking, but what happens is the chemotherapy we're using and the protocols that are used in CLL are further immunocompromising the patients. Often you see with chemotherapy. So the focus is on debulking, but it's at the cost of vital immunity. And I think we suggested that, well, I think when we thought about this, we thought that maybe a way to improve the situation with CLL in leukemia in general, and to improve the survival, long-term survival of patients, would be to try to re-establish immunocompetence in these patients. Try to understand what goes wrong very early on and try to feed these patients with a reasonable level of immunity so they can find a common cold, they can find common infections. So the way the tumor actually can sabotage the immune system, it's many ways, and it's a complicated slide, but it goes two ways. In the one way, the tumor can secrete a lot of immunocompromising cytokines like IL-10, which are known to suppress T-cell activation, and can have other effects also on T-cells. Can really express other things that will disable NK cells, disable CD8 T-cells via expression of IL-6, and therefore it will contribute to that to be a formal loop and continue to disable the immune system. The other thing the CLL cells do is they produce BAFF and APOL, and many publications have shown that this production also is very important for sustaining CLL cells, and it's important in disease as well. So as I said, I'm going to talk about the loss of pDCs in this disease and how we discovered that. So what are pDCs? I'm not going to introduce them because they've been introduced very nicely by previous speakers. But as has been said before, these cells are innate subtype of dendritic cells. Actually, TLR799 should be inside the cells, so I put intracellular. Just the schematic representation is not perfect here. But they are activated through TLR799 to produce type 1 interferon. And type 1 interferon, just to make this very simply, it's maybe oversimplifying, but it's quite important. It's a cytokine which underpins the functions of many immune cells. So you need it for DC function, monocytes, T cells, and B cell function. So we know, and we've heard it before, that for host defense against infection, type 1 interferon production by pDCs and other cells is very important. So, as I said, interferon alpha beta is produced by many cells, but the natural, what we measure, actually the low level of interferon that you can measure in healthy individuals or healthy mice is mostly produced by pDCs. So they're just responsible for the steady state, healthy levels of interferon. So the way the slides work is on the left side you'll see the patient data, and on the right side you're going to see the mouse data. So what we've measured here is interferon alpha in patients and in mice. And in patients, either healthy donor HD or patients with indolent CLL or progressive CLL. So generally in healthy patients we don't detect a lot of interferon, but what you can see clearly is as the patients progress with the disease, we're detecting even less. And that the same happens in mice. That these are the wild-type mice, and at 1 month, 6 months, or 12 months, but as the TCR1 transgene mice, which are the CLL model, which is the CLL model in mice, you can see that decreased expression and decreased detection of type 1 interferon. So when we saw that, of course, we knew that steady-state level of interferon that you normally detect at low level in healthy individuals was due to pDCs. We felt, well, maybe we got an issue with pDCs. So we stained for pDCs in patients, and you can see them nicely, in the patients with healthy. We can detect them still in patients with indolent CLL, but we failed to detect them in patients with progressive CLL. And then when we looked at the mice, this is here at 1 month or 12 months. So at 1 month we see less, but we still detect pDCs in these mice. But then at 12 months, we basically hardly detect anything. So the pDCs also track with disease states, and there, Damien made a very interesting observation. So when we look at pDC numbers per liter of blood, so trying to get an absolute number of cells, in patients with indolent disease, we see actually a lot of patients with high numbers of pDCs per liter of blood. But these numbers crash dramatically as the patients progress with CLL. Whereas the mice, remember, it's a model of progressive CLL. What we see between healthy and 12-month-old mice is a strong decrease in the absolute numbers of pDCs. So if you go back to the table of markers that are less favorable or more favorable, then we have two additional things we can look at. So in indolent patients, we see less interferon, and we detect less, and even less or hardly anything in patients with progressive disease. But the thing we've noted that we distinguish the two categories of patients is that patients with indolent disease can have higher number of pDCs. But whereas with progressive disease, whether it's mouse or human, we see less pDCs and hardly detectable pDCs. So what's happening here? We have a lot of pDCs, but by the same token, the steady-state levels of interferon is quite low. So we suspected, well, maybe the pDCs are defective in making interferon, so we decided to test that. So as I said, the pDCs respond to activation of TLR7 and TLR9 to produce type 1 interferon. So when we did these experiments, well, first of all, we decided to look at TLR9 expression. And then TLR9 expression in pDCs, this is expression in healthy donors, but as you can see, as the patient progresses, we're losing expression of TLR9 on the pDCs, and it's quite low in patients with progressive CLL. It's the same in the mice. As the mice progress at 12 months, we're seeing less TLR9 expressions in the pDCs. So what about the response? And the response is the same. So in response to CpG activation, you can see that with the healthy donors responds very well with CpG, but not so much the indolent pDCs from indolent patients, and even less so the pDCs from patients with progressive CLL. And the same in the mouse was shown. So with CpG, the pDCs responds nicely and produce interferon, but then we have decreased production with CpG when the pDCs were purified from the CLL mice. So we got an additional marker here that distinguish less favorable and more favorable disease. Is we see reduced TLR9 expression on the pDCs and hardly any expression of TLR9 in the pDCs from mice with CLL or the patients with progressive CLL. Okay, so what is the cause of reduced pDC numbers? So what I've shown you so far is we have two different pictures here. In patients with indolent disease, lots of pDCs, they're not very good. They're not making a lot of interferon because they don't express a lot of TLR9. And then in progressive CLL or in mice having progressive CLL, then you see hardly any pDCs. You can hardly detect interferon, and we don't see TLR9 expression hardly in the cells. But why is that? Why are we losing the pDCs as patients progress with the disease? So the first thing we looked at is in the bone marrow, and look whether or not we were losing production of pDCs from the bone marrow. There was sometimes in CLL, especially in progressive CLL, you can have what we call packed marrow, where the bone marrow doesn't function well anymore because of the disease and the number of cells and the progression of the cancer. But that wasn't the case. We had a patient here with progressive CLL, but we can still detect pDCs in the bone marrow. It's the same in the mouse at 12 months. We can still detect perfectly well the pDCs in the bone marrow. So it's really in the periphery that something's going wrong. And in fact, when we take the bone marrow of our mice at 12 months and we culture with FLT3 ligands, we are capable of generating pDCs from the bone marrow. So we don't think the bone marrow itself has an issue. It's more something in the periphery that went wrong. So we looked into the literature, and the one thing we knew is that FLT3 ligands is very important for the persistence of pDC and their expansion in the periphery. So we were wondering whether the levels of FLT3 ligands were impaired. And when we look at the patient, actually not at all, and that was something that was known from the literature. And in fact, patients with indolent disease had more FLT3 levels than patients with progressive CLL. And that may explain why we have more pDCs in some of these patients. And the same in the mouse at 12 months old when they're having active disease, we see a lot more FLT3 ligand. We detect a lot more in the blood than we detect, of course, in healthy mice. So FLT3 ligand is not the issue. And if anything, FLT3 ligand may explain why we have more pDCs in patients with indolent disease. Now, what about the receptor? Because it's one thing to have the ligand, but you need to think about the receptor. And interestingly, the receptor also allowed us to distinguish between patients with indolent and patients with progressive disease. And patients with indolent disease, the pDCs had more FLT3 expression on the cells. And that also may explain why we have more cells in these patients compared to, or many of these patients compared to healthy donors or even patients with CLL. But we see reduced expression of FLT3 as patients progress with CLL. And the same was seen in this model here of progressive CLL. As the mice progress, we saw less FLT3 expression on the pDCs. Okay, so here we are. we've got another marker that distinguishes indolent or less favorable and more favorable disease. Is in patients with indolent disease, there's lots of FLT3 ligands and there's lots of FLT3 expression on the pDCs. And that may explain why we have more pDCs in many of these patients. And in some ways, because these pDCs are not very good at making interferon, because they don't express a great deal of TLR9, it's almost as if the patients are trying to maintain a balance, where they're compensating with numbers of pDCs, the fact that each pDC is not very good at making interferons. It's trying to preserve a balance with a low level of interferon that will maybe be enough to fight most infections. Okay, here we are, but why is FLT3 expression impaired? So again, looking at the literature, there are two cytokines that have been shown to downregulate FLT3 expression on pDCs. It's TNF and TGF-beta. So we look at TNF in the serum, and again, that was known as well. But what was interesting is there was a difference again between patients with indolent CLL and patients with progressive CLL. His serum level of TNF were pretty normal in patients with indolent disease, and it's really high in patients with CLL. And it's the same in the mouse. And that may explain as patients progress, there's more TNF, and you don't regulate FLT3 on the pDCs, but that doesn't happen in indolent patients. So in indolent patients, lots of FLT3 receptor and lots of FLT3 ligand, lots of pDCs. So the one thing I said here is serum TGF-beta not elevated. So I'm not showing that, but we didn't see any difference in TGF-beta level. So we decided, okay, well, if we have an issue with TNF, so the tumor cells are making a lot of TNF, and we know that, and maybe TNF is responsible for FLT3 downregulation, and therefore that's why we're losing the pDCs in aggressive disease. So the next step for us was to treat the TCL1 transgenic mice with anti-TNF. And in this experiment also Damien introduced anti-TGF-beta. And that's interesting because I told you the level of TGF-beta abnormal, but what we see in both cases here is we see increasing pDC numbers in the spleen. So anti-TNF and anti-TGF-beta were very good at reversing the problem and just reintroducing, restoring pDC numbers in the disease. And then at the same time, which was very exciting to us, is when we look at tumor cell burden, we saw reduced tumor cell burden, so reduced tumor cell numbers in both treatment, which sort of told us that when you restore pDCs and when you restore their ability to produce interferon, maybe you're inducing greater immunity in the animals, and they're more able not just to fight infections, but maybe to fight the tumor at the same time. So, and we look at interferon as well, the two treatments were able to upregulate interferon. So we were gaining a better production of type 1 interferon by blocking TNF or blocking TGF-beta in the mice. But why is inhibition of TGF-beta protective if levels of TGF-beta are normal in CLL? And that puzzled us for a little while because we didn't quite explain. We were a bit worried about the data, but finally we found the explanation. And the explanation goes with TGF-beta receptor 1. And it turns out it's quite high on the pDCs of TCL1 transgenic mice. And literature has shown very nicely that when you increase the level of TGF-beta receptor 1 on cells, you increase the sensitivity of the cells to TGF-beta. So even if you have normal level of TGF-beta, the cells with higher TGF-beta receptor 1 will be much more sensitive to it. And that's probably why they're losing FLT3 as well through TGF-beta receptor 1. So the question we had, of course, because I alluded to something, again, it's preliminary, but we have some data suggesting that anti-TNF does much more than restoring pDCs, much more than restoring type 1 interferon and reducing tumor burden. We have some evidence, at least with CD8 T cells, that we also restore the number of CD8 T cells, which is also a big problem in CLL, where CD8 and NK numbers are down and the function is affected. Well, what I don't have here, and I can't show you today, is whether or not those cells are effective at fighting the tumor or fighting infections. So just the summary really to show is that really we've through this work we've been able to find new markers that help us discriminate further the disease between patients with indolent disease and patients with progressive disease. And it's really around pDCs, and we've demonstrated why we're losing these pDCs, and we've been able to show, at least in the mouse model, a way to restore pDC numbers in CLL, with, we hope, some impact in restoring a much better immune system in the mice, and increase their ability to fight not just infection, but fight the tumor. But I think looking at pDC numbers also is very interesting, and it may have a useful clinical, it may be a useful clinical tool for tracking disease stability. Because what we're trying to do now, and that's what's been introduced in the clinic here, is trying to see if we follow patients over time and they have, say, a higher pDC numbers, we may suspect that they might be staying in the indolent phase of the disease. But if we see the numbers going down, we might tell the clinician, look, we think that person is going to progress, very soon, and therefore maybe we should think about treatment. Now, as I said before, it is not useful currently to treat patients with indolent CLL, because the treatment, again, is chemotherapy. It's very immunosuppressive, and studies have shown there's no benefit in treating patients with indolent CLL. And in some ways, it makes a lot of sense, because chemo will further immunocompromise them, so you're not going to help them. But there are new treatments for CLL that are being tested at the moment. And intervening earlier may have some benefit with these new treatments. So I'm thinking BH3 mimetic on one hand, but there's another treatment that's being trialed in CLL at the moment, which is called lenalidomide. And lenalidomide is actually a TNF inhibitor. It's similar to thalidomide. So it would be very interesting for us to be involved in this study and check whether or not the pDC numbers and the immunity of these patients is a bit better with this treatment. So finally, it's just a summary slide to show where we're sitting here. It's a new defect that we've detected in CLL, and something that allows us to distinguish two categories of patients and maybe intervene in the future to treat this disease. And I would like to thank the people who've done the work. So again, big thankful to Damien. Damien's done fantastic work doing this and finding all the different explanations to all the results he's gone, and he's been fabulous with this work. Collaborations, of course, with Margaret and Fabienne Mackay and Melanie, who's here in the audience, which is great. And then I would like to thank also all the clinicians who've been helping with this work, Andrew Weiss, Stephen Ting, and Professor Steve Jane, and Dr. Constantine Tan from the Peter MacCallum Institute, and also Professor Carlo Crossi from Ohio University for the mice. So, and the support, of course, from International Cancer Support and NHMRC. Thank you very much.